Hey NCS podcast listeners, this is your host Fawaz Mufti from Westchester Medical Center. With the rapid evolution of neurocritical care, better comprehension of acute brain injury, as well as the relatively rapid influx of new medications, today more than ever, neurointensivists find themselves engaging and partnering with critical care pharmacists. From sedatives, hyperosmolar agents, vasopressors, or more specifically anti-epileptic agents, neurostimulants, or reversal agents, the pharmacotherapy of acute cerebral injury is undoubtedly complex and multifaceted. Hence, the NCS podcast decided to partner with the highly successful Pharmacotherapy of Neurocritical Care series, the PONS, in a limited release to cover pertinent pharmacological topics presented by experts in the field of neurocritical care. Over the course of the coming months, you will hear a number of selected PONS talks, but please do let us know if there are particular topics you would like to be additionally covered. Without further ado, here's the PONS.
Hello everyone, and welcome to the Neurocritical Care Society podcast. I am Marinaz Pajman, co-chair of the Pharmacotherapy of Neurocritical Care series, also known as PONS Subcommittee. It is a pleasure today to have Dr. Ruben Santiago, an emergency medicine pharmacy specialist at Jackson Memorial Hospital in Miami, Florida, join us to discuss his PONS presentation on reversal strategies for direct oral anticoagulant, also known as DOACs, associated hemorrhage. Ruben will describe laboratory assays for detection of these agents, identify reversal strategies for life-threatening hemorrhage due to DOACs, and briefly evaluate the current data for the use of some of these reversal agents. Ruben, welcome today to the Neurocritical Care Society podcast. Before we delve into this very timely and hot topic, can you tell our listeners a little bit about your background?
Yeah, absolutely. So my name is Ruben Santiago, and just like Marinaz said, I'm an ED pharmacist over at Jackson Memorial Hospital in Miami, Florida. We're a level 1 trauma center, also a comprehensive stroke center. So when these patients do present on a DOACs that require reversal, the pharmacy department is integral in that process. For myself, I'm a PGY1 and PGY2 trained. I did my PGY2 at the Ohio State University in emergency medicine. I worked for a while as an evening pharmacist in the emergency department at Boston Medical Center, before becoming one of the pharmacy specialists in the ER at Jackson Memorial Hospital.
Great, thank you. So let's just get started. So what are the DOACs? And I guess how do these agents compare to warfarin? And how does their bleeding risk compare to that of warfarin?
Yeah, so the DOACs, they kind of like had different names. If you look at them in time, they were kind of like the NOACs or the novel oral anticoagulants, and they're also known as like the SOACs or the target-specific oral anticoagulants. Now we kind of adopted like the DOACs as kind of like their namesake now, or direct oral anticoagulants. And they kind of comprise like the factor Xa inhibitors, so rivaroxaban, apixaban, doxorubicin, and now betrixaban, and also direct thrombin inhibitors such as dabigatran. So they have like a lot of differences in the way they work versus warfarin. Warfarin is, of course, our vitamin K antagonist, whereas, like the name says, we have the factor Xa, where it only works on that part of the coagulation cascade for the Xa inhibitors, and then also direct thrombin inhibitor with dabigatran. The half-lives are also different between the medications. So with warfarin, it has a lot longer half-life that we have to worry about versus the DOACs, with their half-lives ranging between about 5 and 10 to 15 hours, depending on which DOAC you're looking at. So those are some of the key differences between the two. So when you look at the bleeding risk between the two, so all the anticoagulants have an inherent risk of bleeding. And when you're looking at intracranial hemorrhage, patients who receive anticoagulation, they have a higher likelihood of a secondary hematoma expansion and increased risk of death when you compare them to patients with intracranial hemorrhage who aren't on anticoagulation. With large trials comparing warfarin with DOACs, the risk of intracranial hemorrhage was significantly lower with patients on the DOAC therapy. And then this is also shown through meta-analyses that compared warfarin with DOACs that show decreased rates of intracranial hemorrhage, major bleeding, and major bleeding mortality.
Great, thank you. So what are some of the laboratory assays available to assess either their presence or to detect if a patient is super therapeutic on these DOACs?
Yeah, definitely. So like with warfarin, it was very easy to see, like we can measure an INR and okay, we know that someone's on warfarin, has a high INR, they're super therapeutic, we can go ahead and really reverse that. With the DOACs, it's a little bit more tricky. The advantage of being on a DOAC is you don't have to have these routine laboratory parameters measured. The disadvantage when it comes to reversing a DOAC is you don't have routine laboratory parameters that we can go ahead and measure their effectiveness. So it depends on the DOAC that we're trying to reverse with what laboratory parameters that we need to measure or try to obtain. So with dabigatran, There are a couple of tests that are available that we can get, such as if you look at the trials that measure the effectiveness of Paxlovid or Doxorubicin that we're going to get to in a bit. With reversal of the bigotrend, they used eccrine clotting time or a dilute thrombin time, which aren't widely available for us to use to measure effectiveness of reversal. So what we have available to us, or what's widely available, is a thrombin time that you can get, and also the activated partial thromboplastin time, or APTT, that may be used to kind of measure if your patient's on it and how much they're on the bigotrend. Thrombin time is really sensitive to the presence of the bigotrend, and even in low concentrations could exceed the limit of detection of the assay and yield a measurable result. So basically, if we have somebody who's on the bigotrend, the thrombin time might be through the roof. And that just kind of tells us, okay, they're on it, but it doesn't really tell us anything more about it, just that they're on it. So if you have a patient with a normal thrombin time, it probably helps us in ruling out the presence of clinically relevant drug levels of dabigatran. APTT is a lot more sensitive to dabigatran than the PT-INR, but it's also variable with the reagents used for APTT, and therapeutic levels do not always correlate appreciably with the effects of dabigatran and the APTT level. But that's kind of like our best bet is getting a thrombin time and an APTT for patients on dabigatran. For 10A inhibitors, prothrombin time is going to be a lot sensitive marker than APTT. There are like chromogenic factor 10 assays, and that's what they've used in the trials assessing the reversal effect of Endexa for rivaroxaban and apixaban and so forth, but those are also not widely available and not FDA approved at this time.
Do you have any idea when they will become FDA approved?
I do not.
Yeah, because we currently use a thrombin time for dabigatran, but again, I do understand that some centers may use an anti-10A level, either low molecular weight heparin. Is that something that you can use to detect their presence?
You can, but it's also variable, and it's not always standardized. So you don't always get like the best result. So there are chromogenic factor 10 assays that they used in trials to assess the reversibility of Endexnet, which we'll speak about in a second. But those factor 10 assays are not widely available, and there are no FDA-approved calibrators yet. And they're best used if they are calibrated for that specific agent. So if we're reversing rivaroxaban or apixaban. There are variable results that occur between labs, and whether you're using, if you want to use an anti-factor 10A assay with different reagents for either low molecular weight heparin or a heparin calibrator, those are variable results that it would still we would use prothrombin time in those cases still. So for the 10A inhibitors, your best bet is using the prothrombin time to kind of measure if they're on the medication. It doesn't measure how much they're on or what's the concentration of the medication that they're on. It just measures that they're taking it. There are chromogenic factor 10A assays that you can also use, and that's kind of what they measured for the reversal studies with Endexnet when looking at rivaroxaban and apixaban. However, the 10A assays have to be calibrated for that specific drug. So if we're reversing rivaroxaban, it would have to be calibrated for that, or apixaban to calibrated for that. There are variable results that occur between labs that have different reagents in either low molecular weight or a heparin calibrator. So it's still on the side of using prothrombin time to kind of measure if they're on a 10A inhibitor or not, such as rivaroxaban or apixaban. You can also use TEG or thromboelastography. It's kind of like a bigger lab marker that we're using nowadays in our trauma populations and our patients that are bleeding that need massive transfusion. And then what this is a TEG is going to measure the speed of coagulation initiation, the kinetics of clot growth, clot strength, and also clot breakdown. And when we look at the different sections of a TEG, there's something in the beginning called an R time, which kind of represents all your clotting factors. So the R time is the most sensitive parameter on the TEG to the direct oral anticoagulants as a whole. However, the results are still variable and require further validation and standardization for patients who present on any of the DOACs and looking at a TEG.
So with respect to the TEG, there's the TEG 6S analyzer. How does that...
Right.
Is there any data with that in the DOAC?
There is, and it kind of sounds like a brand new shoe when I first thought like a brand new set of Nikes. Oh, look at the new TEG successes. But when I was looking at it, it was like they did it, and it's a new calibrator for the TEG specific for DOACs, but they measured it only so far in healthy populations. And they kind of like spiked blood samples of the DOACs, like the dabigatran, rivaroxaban, and apixaban. So that still needs further validation in our patients that present on this medication, whether it's a trauma patient or a patient who comes in as a stroke alert and ends up having a hemorrhagic stroke, and kind of seeing how it works in real-world population.
Thanks. So So as far as what is in our current armamentarium for reversal, what do we have that is available currently that clinicians can use to reverse these agents? And what are the differences between the agents? Also, is cost an issue with some of these reversal agents?
Yeah, absolutely. So the reversal agent you choose all depends on what your patient comes in on. So if a patient is on dabigatran, we're going to use a different reversal strategy versus patients who present on one of the 10A inhibitors. So for dabigatran specifically, what we would use is something as a reversal agent called idarucizumab or Praxpine. That's what's currently first-line treatment according to our guidelines right now for reversal. So the evidence for using idarucizumab comes from the two big studies, the reverse AD trials, the interim analysis and the full cohort analysis that were published recently. And what they found in those studies is that you had maximum percentage reversal based off dilute thrombin time and eccrine clotting time within minutes. But some of the controversies or things to consider with these studies is that there was a rebound effect that was seen within 12 to 24 hours after patients received a dose of idarucizumab in their clotting times. And this is thought to be due to the redistribution of unbound dabigatran from the extravascular to the intravascular compartment. Other agents that you could use to reverse dabigatran specifically, there's some evidence for using also 4-factor prothrombin complex concentrates, such as Kcentra, or you could also use activated prothrombin complex concentrates such as FIBA or a factor VIII inhibitor bypassing activity.
So with respect to the PCCs and idarucizumab, so you have a target-specific reversal agent versus the prothrombin complex concentrates. Are there any differences in the findings, and in what patient populations has it been studied in?
So there are different agents that you could use, and at my shop we kind of recommend using activated PCC or activated prothrombin complex concentrates over the 4-factor PCC, such as Kcentra. And there's some differences between the products when thinking about reversal when using these agents. So the activated PCC or FIBA or factor VIII inhibitor bypassing activity, you have all 4 factors present, so 2, 7, 9, and 10, but you have activated amounts of factor 7 within the product. Versus a 4-factor PCC, Kcentra, we just have 2, 7, 9, and 10 coagulation factors, but all in non-activated form. So when you look at the data, and it's not the best data, it's more case series and those types of data, and looking at activated PCC versus 4-factor PCC specifically, you have a little bit better data using the activated PCC. There's no trials or studies I know that are head-to-head comparing idarucizumab with a 4-factor PCC or activated PCC, but guidelines currently recommend that if you don't have idarucizumab on formulary, this would be a suitable alternative option for these patients.
Great. So you talked about the reversal agent for dabigatran. What about for the factor Xa inhibitors? What is available to reverse those?
So for factor Xa inhibitors, what currently was just FDA approved in May 2018 was Andexxa, or also known as andexanet alpha, or coagulation factor Xa inactivated Zozo, which is probably my favorite generic name ever had in the world. And with this agent, it was just the full study was just recently reported in New England Journal of Medicine, and what they found is they used andexanet alpha, which is a recombinant modified factor Xa protein. And how it works, it acts as a decoy that binds to and sequesters factor Xa inhibitors, and it neutralizes their anticoagulant effects. So it'll prevent the factor Xa inhibitor from binding to endogenous factor Xa, and that's how the reversal happens with these agents. So the trials that looked at it, you had the Annexa A and the Annexa R trials. With these two trials, they actually just had healthy older volunteers, and they just established the safety and efficacy of apixaban and rivaroxaban reversal in these studies. And you had a decrease in active factor anti-factor Xa activity. When looking at the trials and looking at how andexanet works, when you look at the bolus and then the bolus plus infusion groups, you had an automatic increase back to placebo levels of anti-factor Xa activity once the bolus or the infusion was completed. So that was a little bit concerning. However, these trials were followed by the Annexa 4 trial. And with the Annexa 4 trial, first specifically, it had a lot more patients with intracranial hemorrhage. About 60% of their patients or their patient population presented with an intracranial hemorrhage that we would use. And they found a 92% decrease in anti-factor Xa activity. Well, what they found was, interestingly enough, is that the author stated that there is no significant relationship between hemostatic efficacy and decrease in anti-factor Xa activity in this patient population. So there are some guidelines that currently recommend Andexxa as a first-line agent for reversing the Xa inhibitors. These are like the American College of Cardiology guidelines kind of recommend this agent, as well as guidance from Anticoagulation Forum recommend this agent. But there are a couple concerns with this agent. Logistically, this agent has to be reconstituted. It comes in an updated version of 200 milligram vials. Previously, it was 100 milligram vials. It has to be kept in the refrigerator. There's a complicated dosing scheme, especially when you look at the trials, depending on what time patients present and also what medication and dose that the patients are on. You would either use a high or a low dose strategy. And then there's huge costs associated with using this medication. If you're using the low or high dose strategy, ranging from around about $30,000 or so to $50,000 or $60,000 for using the drug.
Wow, that's really expensive. How are hospitals supposed to keep that on formulary? And do you think there are any benefits to having this drug on formulary as opposed to the prothrombin complex concentrates?
So with this drug coming out in the literature and being recommended, there have been a couple of other studies that have come out recently looking at something that we could use, such as like a 4-factor prothrombin complex concentrate like Kcentra. So when you look at the results of the Andexxa 4 trial and compare them to side by side to results of these other, albeit smaller trials, you had similar rates of hemostatic efficacy, similar rates of thrombotic events, and also similar mortality rates depending on which study you're looking at. So although the newer guidelines are currently recommending Andexxa alpha as first line for apixaban and rivaroxaban, which that's what's it's only FDA indicated for currently. The alternatives include using a 4-factor PCC, and depending on which guideline you look at, they'll either use 25 to 50 unit per kilo dose, or they'll recommend a flat dose of 2,000 units of 4-factor PCC for apixaban or rivaroxaban reversal.
So then you're saying that the 4-factor PCCs should be adequate if an institution does not carry the Andexxa alpha, at least with respect to reversal of apixaban and rivaroxaban. Is that correct?
Correct, yeah.
So what is in the pipeline for new agents?
So what's really exciting is serum parentag is in the pipeline, or PER-977 or Ripazine, known by various names. It's kind of like the, what I like to say, the silver bullet of anticoagulation reversal. So it's going to reverse like your direct thrombin inhibitors, like the Bigatran, your heparins, and also it's going to reverse your Xa inhibitors. The only thing it won't reverse is warfarin. So it's a small synthetic water-soluble molecule, and like I said, it's going to work for these Xa inhibitors and the Bigatran. It works by inactivating anticoagulants via strong non-covalent hydrogen bonds and charge-charge interactions, neutralizing anticoagulant activity. So there's animal studies done and healthy subject studies done that look promising, and it has ideal characteristics that we want in a reversal agent. It's a single dose, it has a rapid onset of action, has a 24-hour duration of action, and so far in the studies that have been reviewed and published, there has been no rebound anticoagulation that I've able to be seen.
Wow, that's fascinating. And what's great is that this is kind of a universal antidote that we could use for a lot of the agents that we currently have.
Yeah, very exciting.
Ruben, do you know if there's a phase 3 trial that's ongoing looking at seraparantag?
Not that I'm aware of. The latest trial I've seen is a trial done in healthy subjects around 50 to 75 years of age that received either apixaban or rivaroxaban, and then they got varying doses of serum parentag, anywhere from 50 milligrams to 300 milligrams. But in this promising small study, patients who got at least 100 milligrams of serum parentag showed complete and sustained reversal of apixaban and rivaroxaban.
Right. So just to wrap up, what are some of your recommendations regarding reversal of the DOACs, and where do we go next with all of this information that you provided?
So one thing is knowing what your patients come in on, or trying to figure out what your patients come in on, and developing a strategy based on the anticoagulant your patient comes in on, whether it's the Bigatran or one of the Xa inhibitors. If it's the Bigatran, knowing kind of like what labs to getting a thrombin time or APTT. For the 10A inhibitors, getting a prothrombin time, and also getting a tag in this patient, even though it's not standardized across the board, it could still help with the overall clinical picture of your patient and how they're bleeding and how their blood is working. Also know what your hospital carries. If your hospital doesn't carry one of these newer antidotes, knowing what the 4-factor PCC or FEBA that they carry to help expedite in this situation to provide that optimal care and quick care for these patients, and everyone gets kind of nervous when you have a patient who's on a DOAC and who's also having a major life-threatening bleed. And if you do have these newer antidotes, having a low threshold to provide supportive care, such as maybe we need to add a PCC in addition to the antidote in these patients. And also make sure that you establish order sets and guidelines for use to have a streamlined process when something like this occurs.
Ruben, thank you so much for your time today.
Thank you guys so much for having me.
The NCS podcast is produced by the Neurocritical Care Society, whose mission is to promote quality patient care, professional collaboration, research, training, education, and advocacy in neurocritical care. Our production staff includes Romani Ballou, Mike Brogan, Josh Levine, Sarah Stern-Nezer, Benjamin Miller, Storeen Shepard, and Chris Zaman. Our administrative staff include Angel Gindel, Sarah Mimmin, and Becca Stigman. Music by Lee Rosever under a Creative Commons license. The Neurocritical Care podcast series is available on NCS On Demand and wherever you may listen to your podcasts. For more information, please follow us on Twitter at Neurocritical or Facebook. I'm Fawaz Al-Mufti, and thanks for listening.